No, there's nothing. There
Okay.
are no deep, dark secrets.
Okay. All right. I shall shut up now and hand over to you guys. Yeah.
Okay, I'll give it a minute for people just to drop in.
Thank you again, Martin.
Well, my pleasure, always.
Thank you. All
And
right.
next
I shall
time
shut up now.
next time I'll come in person.
Oh yeah, yeah,
I
absolutely.
have to look for an
Yeah.
excuse. I need to look for an excuse to visit Australia again. It's been a number of years.
Okay. All right. It's a plan.
Recording in progress.
Oh, is that you?
No,
Wait.
no, no. That's Professor Thong wants to do an AI generated thingy. Yeah.
Okay.
Okay. So I'll shut up now.
Okay.
Bye. Yeah.
I will start the introduction. Wait, let me record. Okay. Welcome everybody who's joining us with another Australian neonatal lectures. It is my great honor to introduce Professor Martin Keszler. I think that's just such a name which everybody knows once they started neonatology, because neonatology used to be ventilation only. But I think things have changed, and we were just chatting that Martin has gone through the whole pre-era of building components in ventilation, pre-surfactants, surfactants and steroids, up until now, where there is changes in your population, changes in what the machine can do, and I think we can really learn from his expertise. Today he's going to talk about high-frequency jet ventilation and the difficult patients, was my understanding. Martin, over to you.
Thank you so much for your kind introduction, and thank you to Julie for asking me to do this. Apparently, you all have had some challenging patients, and you are fortunate enough to actually be one of the few to have access to jet ventilation outside of the United States and Canada. This is my task, so I will jump right in. I have to start with an apology, because these days I have to do that every time I travel abroad or speak abroad. There's this bad guy that's causing a lot of grief to everybody. You folks are a little bit more insulated, I suppose, but Europe and the rest of the world is struggling. But anyway, here we are. Oh, there we go. So, I want to make this important point, which is we have great tools nowadays. Wasn't the case when I started in the 1970s and 80s, but now we have very sophisticated devices. The engineers are doing a great job, but these are tools, and tools need to be used to best advantage. And to do so, we have to understand the pathophysiology we are treating. We have to individualize our care, because no matter how good the tool is, if I'm using it the wrong way, with the wrong strategy, to do the wrong job, applying it to the wrong patient, we're not going to get the results that we are hoping for. So I am a big believer in individualized care and in understanding the pathophysiology and tailoring strategy and using the appropriate device when it's, oh, there he is again. All right, let's get rid of him. I hope we can accomplish that for real. Anyway, you have jet ventilators. You've had them for some time, apparently, and are quite good at using them, I'm sure. So I don't need to spend a lot of time talking about the basics. I don't know if you have the new model. They are stopping to support the old one. There's functionally very little difference. It just looks prettier and has more advanced electronics on the inside. And as you know, the jet functions by squirting little pulses of gas, maybe not so little if the baby is sick, down the center of the airway through this special adapter, measures the pressure distally, and adjusts the pressure head here to maintain user preset peak pressure. We'll get back to the concept of the servo control and whether that's what we still want to do. That's another story. But the The result is this very unique pattern of gas flow that accounts for a lot of the advantages of jet ventilation, where the gas stream emerges from the endotracheal tube as a compact bundle and streams down the center of the airway and actually displaces air that's resident in the large airways, and there is simultaneous coaxial flow, which can sweep out secretions and meconium. That's all very important, but it is equally important because of the nature of that gas flow that we keep the head straight, and that we avoid this bayoneting of the trachea when the head is turned at right angles. So one of the things that I'm sure you are paying attention to, but if there are any trainees, important issue, keep the head straight, keep the stream down the center of the airway, and you'll do much better. You can actually use the streaming to advantage. This is just a little trick that I've come up with over the years, because sometimes you have tension PIE, and in the past we would sometimes selectively intubate, physically intubate the mainstem bronchus on the opposite side to try to let that tension PIE resolve. But our patients are getting smaller, and it's getting harder to put a tube in a very small patient into the right mainstem bronchus, but you can virtually intubate by advancing the tube and making sure the bevel points to the side you want to preferentially ventilate, and advance the tube a little bit, and you can really aim this jet stream at that particular mainstem bronchus, and it really works. You can see this was under tension. This is 12 hours later. It's not fully resolved, but the tension's resolved and things are improving. But there's just a handful of cases, never been published, but it's a little trick that might come in handy once in a while. So we talked before we actually officially got started about how, when in the late 70s, when I was a resident, in early 80s when I was a fellow, we had some homemade equipment. This was a fluidic jet ventilator, no moving parts, doesn't need electricity. We had this homemade bent metal needle, and off we went. And you had to be a little bit creative back then. Now we have these wonderful devices, and they're quite sophisticated, and they allow us to do all the good things, but we need to be careful. So, jet ventilation is nothing new. I started working with jet ventilation during my fellowship, and in those days, it was all about late rescue, right? Babies who were doing terribly. This was before surfactant, before a lot of steroids were used. Babies were having a lot of air leak. And, it worked, but it was usually kind of late, and babies ended up with lots of morbidity and sometimes mortality. So once we realized that we weren't killing babies with the jet, we moved toward early rescue, and that's where most folks still are. These are very premature babies, or babies at high risk of complications, maybe some degree of pulmonary hypoplasia, babies who are requiring high pressures. Works pretty well, and it remains pretty much the standard approach. And then, of course, what about first-line treatment? And for a long time, only a handful of places were using jet ventilation as a first-line treatment, mostly the reluctance related to the fact that it's really easy to inadvertently overventilate with the jet. It can, I always say, it can ventilate a rock. If you're not careful, you can really overventilate. And there's plenty of evidence in the literature of bad outcomes when things get out of hand in terms of hyperventilation. So it is now becoming more embraced, though, in the extremely immature babies. So the modern era, maybe we are going to be seeing a bit more primary use. In general, the reasonably well-established and accepted indications are listed here. Only a few are based on randomized controlled trials. PIE and air leak is pretty much where we started with jet ventilation. That was always the initial approach. And there is a randomized controlled trial that we did a number of years ago in the late 80s, published in the early 90s, where it did work. There is other evidence for air leak, large air leak, bronchopulmonary fistula, esophageal fistula. I'll show you just a smattering of data. Then just general rescue. This is based on only a large observational study, a large cohort study. There's a couple of small studies, but it clearly works well in this scenario. Pulmonary hypoplasia and diaphragmatic hernia are reasonably accepted indications, but no randomized trials to speak of. And now we have a lot of interest in using it for the extremely immature 22, 23 week babies. And that's been pioneered by the folks in Iowa and being embraced by many others now, but with only anecdotal evidence for the benefit. So just very briefly, some of what the data on which we all base our use of jet ventilation specifically for air leak. This was a randomized study, a relatively small one, 144 babies. Again, old days where there was a lot of air leak developing, so we were able to recruit a fairly decent cohort in just a few years, and it did work. But it was complicated to do a study like this when we all had, or most of us had experience for several years seeing babies respond well to jet ventilation, and now how do you do randomized studies and randomized to what you believe is the inferior treatment. This has been a dilemma for clinical trialists for a very long time. The experts who are familiar with the treatment are often reluctant to do the study because they no longer have equipoise, and the skeptics maybe aren't very good at doing it. So, oops, sometimes things run away from me. How do we get back? Here we go. So it did overall result in significant improvement, and we did not base this on full resolution of PIE because many of these babies went on, never fully resolved PIE, just blended into BPD. Little bubbles became more cystic changes of BPD. So there were specific criteria for failure and for success. And if you succeeded, things were well, but we did allow for crossover because nobody wants to see babies die. We were criticized for that, of course. But it was interesting that not only initially when you started on jet ventilation, you were much more likely to succeed, but those few who failed on jet ventilation almost always also failed after crossover. Only a small proportion benefited. Those who failed conventional ventilation, nearly half of them had a good response and eventually recovered. About 40% had at least transient improvement, but ultimately did not. And 16% continued to do badly. So yes, it was somewhat flawed on that basis, but the fact that if you succeeded, you lived, and if you met failure criteria, you died, somewhat validated the criteria that we used. So this is for those of you who didn't go back to the literature that far back, that's what we got. And why does jet ventilation benefit in air leak? Well, typically there is some breach, right? Some tear in the tissue through which air can escape, and it'll take certain pressure to open that rent enough to actually cause gas to escape. And with conventional ventilation, which has a significant inspiratory time, that pressure remains above whatever threshold there might be for gas to escape. And so you're going to have a lot of gas escaping, and PIE worsens or fails to improve. With jet ventilation, the pulses are very short. As you know, the inspiratory time is extremely short. So you have less leak. But when we started doing this, we also believed that you need very minimal mean airway pressure. And Bunnell always emphasized the low mean airway pressure, which kind of made sense, and it did work. We did it that way in that study. But typically, you ended up trading off overexpansion with PIE for atelectasis when you reduce your pressures too much. But then it turned out, and we've now learned that, yeah, you can increase your PEEP. You don't need to be PEEP-ophobic, even with PIE, because the threshold is still not going to be, there's still not going to be a leakage during the expiratory phase. And so you can maintain better aeration and don't have to sacrifice lung inflation, because as we all know, maintaining optimal lung inflation is critical in terms of minimizing lung injury. So it doesn't make air leaks worse. It maintains better aeration. So that's a strategy that is currently favored for treating PIE. And of course, when you have a hole in the larger airways with conventional ventilation, where the pressure is equally applied throughout the tracheobronchial tree, the air will take path of least resistance and come out the hole. With jet ventilation, because of that unique gas flow pattern, there's virtually no lateral pressure on the tracheal wall. And we've done this in the lab. You can cut a hole in the trachea 1 centimeter square and jet right past it, and it works really well. So that's where we treat our air leak, and it works really well. So let's talk about a scenario that may or may not sound familiar. I've seen a bunch of babies like this. So this is a medium-sized preemie, born vaginally after premature prolonged rupture of membranes, maternal fever, prompted delivery. Initially does well on CPAP, as these babies often do because of the accelerated lung maturation by exposure to infection in utero. But by day 5, the baby is starting to labor and is increasing oxygen requirement, respiratory acidosis, and ends up getting intubated. And things go okay for a while, but the settings are creeping up. And by day 10, we're starting to be concerned about the lack of progress and, in fact, the gradual deterioration. Get a chest X-ray, and the radiologist reports diffuse bilateral PIE. Okay, well, here you folks are very fortunate to have access to the jet ventilator, so let's change to the jet. That's how we treat PIE. Some fairly robust settings because his baby's been backsliding. PIP of 28, PIP of 6, rate is the usual 7 hertz of 420, the usual inspiratory time. But the results don't seem to be what you expected. The CO2 is not so great. The jet can usually ventilate a rock, so what's with the CO2? pH not so great. And the chest X-ray shows worsening air trapping. Why did the mighty jet fail in this particular patient? And it turns out that, was it really PIE? PIE is sometimes a little bit tricky. PIE is quite often unilateral, as is in this case. So this is PIE, indeed. This too is PIE. It doesn't always have that classical branching pattern. But this is clearly, again, unilateral PIE, and would be appropriate treatment. But this is bubbly, but it's not PIE. This is obviously wicked bad BPD. We say wicked in Rhode Island here all the time. So this is bad BPD. This is bubbly. This is not hard, but a lot of the time it's more subtle. And is this PIE or is this early changes of BPD? Our radiologists call anything bubbly PIE, but PIE doesn't develop on day 10. PIE usually develops early on, almost always in the first day or 2 or 3. And part of the reason is there's more fluid in the interstitium. And of course, the premature babies have more interstitial tissue to begin with. It doesn't, you don't get real PIE beyond the first few days of life. So this is probably not PIE. This is probably BPD, early changes of BPD. So is this. But our radiologists would call this PIE. And I have to keep correcting them, but it doesn't work. So this has actually been described quite a long time ago now. But it is those babies who were exposed to choreo often do this. This was a retrospective study, as a relatively small cohort, but a lot of these babies were all tested for ureaplasma, and almost half of them were positive. And those babies that were positive were more likely to have a history of chorioamnionitis, PPROM, and to have delivered vaginally in a similar scenario as I described in this case. And as is often the case, they had relatively mild respiratory distress early, but then tended to deteriorate with increased respiratory support. Many more were still ventilator dependent on day 10 with higher settings. And importantly, their chest radiographs showed more emphysematous changes, which started as early as day 5, but even more so on day 10. So this sort of a pattern was described, and in the case scenario that I described, the reason things didn't work so well was that this baby did not, in fact, have PIE. This baby had early changes of BPD. So this early rapid evolution of BPD, which is early cystic change, is an example of where we were using this wonderful tool for what we thought was PIE, but it wasn't. It was a different pathophysiology, and therefore the results were not so great. We'll get back to a couple of those issues again later. So, of course, uncomplicated RDS is perhaps the most common reason nowadays that we use. We don't always wait till the baby already has air leak. What evidence do we have for jet ventilation in uncomplicated RDS? Well, there were 2 randomized trials done simultaneously in the early 1990s, again, mostly pre-surfactant. The results were drastically different. Same device, same population. The populations were virtually identical in terms of demographics, and the results were very, very different. And actually this group was originally going to be part of our study, and then they got some funding for some imaging studies and went their own way and ended up doing things a bit differently. And it's a really important example of how strategy makes all the difference, because the device was the same, the population was the same, the disease process was the same, but the strategy was different. And we had the insight that this is a different disease than PIE, and that the optimal lung volume strategy is appropriate for treating RDS. And so we prescribed a higher end expiratory pressure with the idea of optimizing lung inflation. The Philadelphia group did not make that leap and continue to use the jet the way it was used for PIE, where low PEEP was the standard. And you can see, so all right, so we had good outcomes in terms of chronic lung disease. Statistically significant benefit, no benefit in that area here. But more importantly, there was this big problem with PVL, which was greatly increased in the jet ventilation group. So here it favors conventional ventilation by a pretty wide margin. We did not see that. But when you look at the meta-analysis, and this is the flaw of meta-analysis, it obscures important differences. So you worry maybe jet ventilation causes PIE, but no, it doesn't cause PIE. It's the strategy with which it was used here that caused the no, not PIE, that caused the PVL. And so this was this relatively small cohort of about 70 babies where there was a lot more severe IVH, significantly more cystic PVL. This is a huge 30% PVL, unheard of. Nowadays, PVL is rare. And these combined outcomes were terrible. And if this was the only randomized trial of jet ventilation, then that jet ventilation would be in the Smithsonian and never used in the NICU again. But thankfully, that was not the only study, and our somewhat larger study, but we actually stopped early because the other study published their results, and we said, oh, MG, we got to stop enrolling and analyze our data and see what's going on. And we did actually show significant reduction in BPD, corresponding decrease in need for home oxygen, and not statistically significant, but perhaps a bit less air leak trending in that direction in any case. So that was good. What about the other outcomes? So severe IVH PVL, conventional was higher than jet. So this was the opposite direction, not statistically significantly better, but certainly not worse. But then we came to realize that not everyone followed the prescribed strategy, and there was a subgroup. It was not a large subgroup, but about 20% of the babies were treated the other way, the way they were treated in that other study. And lo and behold, that subgroup also had worse outcomes, and the ones that were treated with the appropriate strategy fared much better. So strategy matters, and the meta-analysis is not always helpful. And it was all about hyperventilation because the way they were used the jet, and I didn't keep those slides in there, but there was massive hyperventilation with pHs as high as 7.6, and we know that's bad. So what about everybody nowadays, and I don't know if you've embraced this idea of using the jet as a primary mode in those 22, 23 weekers, or if you even do 22 weekers, which may or may not be a good idea. Many of us are still struggling with that, and none of us have been able to quite replicate the data from Iowa, but there's some rationale for using jet ventilation. It is a gentle mode. It really minimizes dead space because that jet stream pretty much penetrates through the dead space, so very small tidal volumes are possible. And if used appropriately with optimal volume strategy, it works very well. In North America, is widely available, and many centers have extensive experience, albeit in somewhat larger babies. But there's some drawbacks. It's really easy to overventilate. I have some embarrassing data that I'm not sharing that we've overshot, and so it's important to be really careful with that. You cannot measure tidal volume. You have no pulmonary graphics, unlike volume targeted ventilation, for example. It's a little bit noisy. It's very sensitive to the tracheal tube position. It's a little tricky to ventilate through a 2-millimeter tube, but some of these babies are too small for a 2.5. The evidence is pretty anecdotal, but it seems to work in experienced hands. So what they do over there, and what's generally being trying to be replicated by others, is of course starting as soon as possible after birth. slower rates are needed. And the reason for that is that these extremely immature babies have a paucity of elastic elements in their lungs. So when you take away the surface tension by giving the wonderful surfactant that we now have available, they don't have a lot of elastic recoil. They don't exhale. And because the jet, of course, depends on passive exhalation, you have to give a longer expiratory time, hence the slower rates. Short time, generally low-ish pressures, but higher if you end up having to use a 2-millimeter tube because of the high resistance. Normally, we would be using a higher PEEP, but these babies have dynamic PEEP. They have some air trapping, inadvertent PEEP. So while we're setting the PEEP relatively low, they probably are seeing a PEEP of 7 or 8. We don't use size, of course, because they tend to be overexpanded to begin with. And again, so these are just the standard things. Keep the head midline, neutral position. We advocate using transcutaneous monitoring because it's so easy to overventilate. If there's overexpansion, CO2 retention, it's probably air trapping. These kids just do not exhale, so you got to give them enough expiratory time. Sometimes the rate has to go down really as low as 300. If there is, meticulous nursing, meticulous RT, really important. The sorts of things we talked about. And one thing that's common to all approaches to ventilating these extremely immature babies is not to try to extubate them early. These babies have a high propensity to fail. They can crash. They're unstable. And so there was this paper published a few years back that described different approaches using oscillatory ventilation in Japan, assist control, volume guarantee in Sweden, and jet ventilation in Iowa. And they had many similarities, one of which was do not try to extubate early. So these babies were ventilated for several weeks invariably. A few years ago, one of their publications described the actual settings that their babies were on. When they talk about what they do, they generally talk about lower rate. Here they are, what they described. I think they've evolved toward lower rate than what they describe in this paper, because this is a little bit higher than most of the time you would need that you would use. Relatively low mean airway pressure. Again, that's measured mean airway pressure. Probably distally, it's a bit higher. Note the difference in PIP. So significantly higher pressures are needed through a narrower endotracheal tube. And again, with the smaller tube, higher resistance, they're more prone to air trapping. So it's a little bit tricky, but doable. All right, so in case you wanted to go that way, or maybe already have gone that way, I didn't get to ask that question, but we can talk about it afterwards. So let's talk about another case. A little 25-weeker, borderline OEGR, typical clinical and radiographic signs of RDS. In this case, started on jet ventilation to try to minimize lung injury, pretty low settings, low-ish PEEP. Maybe you could use a little bit more in a 25-weeker. Because the I time is so short that the mean airway pressure is barely above the PEEP. The PEEP is by far the most important element in mean airway pressure. Usual starting rate, etc. Everything looking pretty good for the first few days. FiO2 is weaning, gases are acceptable, quite reasonable. A little bit of weaning occurs. And so everybody's happy at this point. But then nothing much improves over the next 2 weeks. Baby's still on the ventilator, still on the jet. Maybe a little bit of backsliding. FiO2's down a smidge. PIP is up a little bit. Well, permissive hypercapnia is appropriate at this age, so better compensation. Nothing worrying, but no real progress. So that's a little bit concerning, but it's a little one. All right, let's see. The chest X-ray is pretty well expanded. It's a little bit hazy. Maybe this is the 2-week slump that some of these babies demonstrate. And then life goes on. Now we're at 3 weeks of life, and we're kind of backsliding. Dips now up to 24. FO2 is up a little bit more as well. Gas exchange is, CO2 is building up a little bit. pH is okay. But, we're not heading in the right direction. Got a chest X-ray, and that's showing some overexpansion, flattened diaphragms, and the lungs are starting to look a little bubbly. Oops. Keep having this go backwards for some reason. So, what's going on here? What should we do? Lots of options. There's some debate maybe ensuing at this point. Should we go up on the PIP? Should we go up on the rate to blow down some CO2? Should we increase the inspiratory time? Because you can do that if you think that you need to get a little bit bigger tidal volume for that pressure. Should we go down on the PEEP because of the overexpansion? Should we decrease the rate? Should we change to the oscillator? Because people do that when something isn't right. Let's try a different ventilator. Should we change to conventional ventilation? Should we call the JET hotline? Do you still call the Bonnell JET hotline? Does it work from Australia? I don't know if they accept those calls, but Bonnell's been really good about providing support. You can call them day and night, and they'll try to help you. Anyway, so we don't have audience response here, so this is all just a mental exercise. But why is this baby having CO2 retention and air trapping and overexpansion and not doing so great? Well, it turns out, of course, this baby is now 3 weeks old, and the time constants are getting longer. You all remember time constants, right? It's basically how quickly gas can get in and out of the lungs. Mathematically, it's a product of compliance and resistance. So higher compliance gives you longer time constants. So babies with normal lungs actually have longer time constants. But increased airway resistance is what this is about. As you know, over time, little babies tend to have increased airway resistance. It's a combination of things: mucosal edema, secretions, and other things. But these babies do have increased time constants. And when you have that, you will maybe not have sufficient expiratory time. And if you don't have sufficient expiratory time for the pressure to, at the end of this cycle, to drop back to baseline, you will gradually build up some dynamic PEEP. And as a consequence, your delta P has dropped and your CO2 has gone up. And of course, the lungs are a bit overexpanded, which also compromises lung compliance. So double whammy. That explains the CO2 retention. So, what were the right answers here? More than one option. You could, certainly, this is probably not what you should do, although that's what most people end up doing in this scenario. Increasing the rate's definitely not the right answer. This isn't going to do it either. Decreasing the set PEEP isn't really the answer, because what you're dealing with is dynamic PEEP that you can directly control. But decreasing the rate would do the trick, right? Because that would allow longer expiratory time, would allow more complete exhalation. Again, the jet depends on passive exhalation. So you got to give it enough expiratory time. So lower frequency, lower rate would do the trick. Changing to the oscillator would not be the right answer. The oscillator tends to cause more air trapping in this scenario because of the active exhalation starts to collapse the small airways in babies with evolving and well-established BPD. What I usually do in this scenario is I change to conventional ventilation because there is no longer much evidence, much reason to think that the jet is the right tool. High frequency in general is best for conditions with short time constants. We are not there at this point. We are in a scenario of evolving chronic lung disease, and that calls for a different strategy. Because, of course, this baby doesn't officially have BPD yet, but is heading that way. And when you are in a state of evolving BPD, you are going to start to see these sorts of pathophysiologies. You have increased airway resistance. That's the hallmark of BPD. And it's what makes jet and oscillator not the best approach because the time constants are long. Of course, we're not to this point just yet, but there are issues with airway resistance, and airway resistance tends to lead to CO2 retention and overexpansion. And when the diaphragms are really flat, the respiratory effort isn't very effective. When of course, inspiration, spontaneous breathing requires the diaphragms to be flattened. If they're already flattened, there's not a lot of more flattening you can do. And then, of course, other aspects of arrest of normal alveolarization is another reason for CO2 retention as BPD becomes more established. And of course, then you have also issues related to the abnormal pulmonary vascular bed, the smaller pulmonary vascular bed, because of course, vascular branching follows airways, and airways are reduced. These babies, of course, are prone, as you well know. And of course, we end up with this multi-compartmental lung. Again, this baby is not quite there yet. He's heading that way. But we tend to ventilate small babies like they have RDS, even when they're 3 or 4 or 5 weeks old, where they no longer have RDS. They have more of an evolving BPD, and that again calls for a different approach. This multi-compartmental lung develops gradually, but in the scenario of chorium neonitis, an early evolution of BPD, this can occur as early as 2 weeks of age. And these highly variable time constants make things a little bit miserable, and you have these slow compartments and these fast compartments. So because of that kind of pathophysiology, babies who have evolving or established BPD require a significantly slower ventilator rate because of those long time constants, at least in some portions of the lung. And because of the slower rate, in part because of that, you need a larger tidal volume, right? Of course, minute ventilation is frequency times tidal volume. If the frequency or rate is slower, just to maintain the same total minute ventilation, you need a larger tidal volume. But on top of that, you have increased alveolar dead space. In other words, wasted ventilation. Again, when you have heterogeneous inflation, you have more wasted ventilation. Increased alveolar dead space requires a larger tidal volume as well. So double whammy, requiring larger tidal volumes. Again, the small tidal volumes of high frequency may not be the most effective way to ventilate. We no longer worry so much about hyperoxia, because as these babies mature, they have a little bit better competence in terms of antioxidant defenses, and we want to prevent worsening pulmonary vascular disease that can become a real challenge, as you well know. Permissive hypercapnia is appropriate. We don't know what the safe limits are. We get a little skitsy when it gets into the high 60s or low 70s. And of course, we try to maintain relatively normal FRC and avoid air trapping if we can, which isn't always so easy. These babies sometimes really do air trap, and that phenotype is the most challenging. But this is some graphics from a publication that the BPD Collaborative, a number of us co-authored this paper with Steve Abman as the lead author, and kind of went into the reasons why these slower rates are important. And because of the multi-compartmental nature of the lungs, these fast compartments that have relatively short time constants, if we ventilate a baby with established BPD like they have RDS, we're going to only ventilate the fast compartments. We're going to have poor gas exchange. We're going to have a lot of ventilation perfusion mismatch and CO2 retention because we're not ventilating the entire lung. We'll have increased physiologic dead space, alveolar dead space. And so this is not the most effective way. If you slow things down, then you can effectively ventilate those slow compartments that take much longer to fill and empty. And that will improve ventilation perfusion matching, reduce the alveolar dead space, and improve overall aeration of the lung. So that's kind of the concept. And typically we achieve kind of both by using SIMV with pressure support. So with conventional ventilation in RDS, I always use assist control or pressure support by itself, not SIMV. But in the evolved BPD, it makes sense to have the slow rate, larger tidal volume SIMV cycles ventilating the slow compartments, and the pressure supported spontaneous, somewhat more rapid breathing, ventilating the faster compartments. So kind of trying to do dual ventilation for both types of fast and slow compartments. Anecdotally, it works. We don't have randomized controlled trials, but we all have, received babies from somewhere else who are being ventilated the wrong way, change them to the chronic ventilation pattern, and they improve. How scientific is that? Well, but who can do a randomized trial in that sort of population? That's tricky. But of course, BPD is not all the same. There are different phenotypes. There are babies in whom parenchymal disease predominates and is characterized by arrested alveolar development primarily. There's, of course, airway disease. There is peripheral airway disease in that because of the simplified lung, the peripheral small airways that have no intrinsic rigidity have paucity of alveolar attachments because of the simplified lung and tend to collapse as the lungs empty. And of course, you can have a large airway disease with tracheobronchomalacia. And both of these require higher end expiratory pressure. So that one of the reasons for needing one of the differences in ventilating these babies is they need much higher end expiratory pressure compared to your simple RDS. If the babies have a lot of pulmonary vascular disease and pulmonary hypertension, that clearly complicates things, and that particular component is associated with higher mortality. But of course, many have a mixed phenotype where several of these coexist. And it turns out this was a nice study from just a few years ago where they tried to characterize a bunch of babies in terms of their phenotype and many had all three components. The more of the component phenotypes they had, the worse the outcome. By and large, pulmonary hypertension was not that common, but it was it accounted for a lot of morbidity. So again, it depends on where on the spectrum of this scenario your particular patient is, will drive specifics of your respiratory support and other aspects, of course. But the important thing in terms of this evolving BPD, we don't have a good diagnosis. There's no official diagnosis in our book for evolving BPD, but that's what it is. You can't call it BPD technically till 36 weeks, but we know these babies long before 36 weeks have this phenotype. But it evolves at different times, at different speeds, sometimes very early, as case number 1 illustrates, and sometimes much more slowly. And it's not an overnight thing. People keep asking, well, when do you change to the chronic ventilation strategy? And I'm saying, well, it depends on the patient, right? And so it happens slowly. The cues lie in the flow waveform on your conventional ventilator that shows you increasing airway resistance. Prolonged expiratory phase is the first clue that this baby is moving in that direction. So the ventilator changes need to track the pathophysiologic evolution and evolve with the baby. So you don't go from RDS to BPD settings overnight, but gradually transition. But typically, a lot of babies by 3 weeks of age, if they're on jet ventilation, begin to show CO2 retention, begin to show some overexpansion. And yes, you can keep them on the jet. If you slow down the rate, they'll do fine. And there is actually some suggestion that with the nature of the gas flow, there is maybe a little bit less impact of the different time constants, but the settings need to be different, and I'll get back to that in a minute. So chest X-ray, lung ultrasound, ventilator waveforms are all clues that the baby is changing their pathophysiology from RDS, and we need to change our strategy. So lower rate, longer I time, longer E time, expiratory time, and higher PEEP and higher tidal volume are needed as the disease process evolves. And again, not all babies are the same. They're not, we need to make our best changes based on what we think is going on, and then we need to check with the baby. Baby will tell us whether the changes are working or not. Oops. Yeah, we don't want to get here. You can see this baby is going to have a difficult time generating a spontaneous tidal volume when the diaphragms are already inverted. So this is the extreme. This is the worst phenotype. These babies tend not to do very well if you cannot get them to stop. And these babies tend to, it tends to be a vicious cycle. The baby is distressed because the settings are not optimal, or the CO2 is high, and we can't quite capture them. They become more tachypnic. When they're tachypnic, they air trap because they don't have sufficient expiratory time. And when they air trap and retain more CO2, you can kind of see how it can snowball. Rarely you have to briefly paralyze them, but ideally what we do is make the settings such that the baby slows down their respiratory rate. If you give them a large enough tidal volume and get their pH normalized, they will stop being tachypnic. So typically, once you get to establish severe BPD, so not at 3 weeks, but later on, we typically advocate for SIV pressure support, with or without VG, mostly with. I prefer to use VG in these babies, in any baby for that matter. Some people use the more adult type or PQ type of volume control. Pressure support, slow rate, quite slow. Whatever pressure is needed is what we use, sometimes fairly high because you need those bigger tidal volumes on account of the slower rate and the wasted ventilation. Higher PEEP, longer eye time, and bigger tidal volume as we talked about. And we did a little study a while ago where we actually sent everybody to their NICU or PQ, to look at all their babies and record what settings they were on to see what actually was going on as opposed to what we said we should be doing. And gratifyingly, we actually found that we were doing roughly what we recommended. So relatively high PIPs, relatively high PEEPs, appropriate eye time, and tidal volumes around 9 ml. So, and rate around 20. So it's refreshing to know that we actually were doing what we said we should be doing. So yeah, BPD unfortunately is here to stay, especially with all these surviving 22, 23 weekers. They all will have BPD. So what about oscillatory ventilation? Well, because of those poorly supported peripheral airways, then the active exhalation probably is not the way to go. And people keep trying oscillator in BPD, and it just does not work. There's a couple of papers that did look at what if the baby's failing the oscillator, which of course they will classically, because it's a wrong tool. A very long time ago, a very small retrospective study, not doing well on the oscillator, did better with the jet. Very minimal level of evidence here. Richard Plafka, my colleague from Prague, and I, another tiny paper. Again, jet was better than oscillator, but maybe it's not the best thing to begin with. If you're going to use HFJV in BPD, you need much lower rates, significantly higher PEEP to keep the airways patent, maintain the standing pressure. And pretty high PIP is typically going to be needed. Dynamic PEEP is still an issue. You need a really long expiratory time. So this is just the IU ratio at the normal rate of 420. It's 1 in 6, 1 to 6. As you go down, you allow longer expiratory time to allow active exhalation. So, oops, we've been here already. The servo pressure is something. So Bunnell did this ingenious thing where when he developed the jet in the late 80s, pressure control was all anybody knew, and so he made it a pressure ventilator. So the servo pressure responds to changes in compliance, and if the lung becomes more compliant, the servo pressure goes up because it takes more gas to maintain the set PIP. Well, maybe, of course, that will lead to overventilation. That's really what pressure control ventilation does, but, and of course, the opposite is true if compliance decreases. But we and others started to think about maybe we don't want to do it that way. Maybe if we make it a volume ventilator of sorts by directly controlling the servo pressure. We did a little bench study. I know we're running out of time, so I'm not going to elaborate on this, but with the standard control, as over a 7-fold change in compliance, there was a steep curve, and of course, the more compliant the lung became, the larger minute ventilation, so overventilating like crazy, much less so with manual control. And there was an animal study subsequently done by Robert Displasia with my involvement, and it showed that it sort of does maintain a more stable CO2 and gas exchange in general. So the jets, awesome. This is Bert Bonnell, who came up with this wonderful thing. He's now retired, but he deserves a lot of credit for for this wonderful tool that we all been using for the last 40 years. Oops. It's a great high frequency ventilator. It can do anything the oscillator can. Some things oscillator can't do, but the strategy is really, really important. With RDS, optimal lung volume strategy is important. Pay attention to time constants. But again, best results are obtained when we use the right strategy in the right patient at the right time, and we adjust strategy as the disease evolves. And that's all I have. I'm sorry I didn't allow much time for discussion, but I'm happy to stick around.
No, that's okay. This was fantastic overview. We certainly have some time. We can certainly make some time because there's a lot of questions. Look, this is a great overview, as always, the history of the jet ventilator, how it works, where it works best. And then what I like, you showed some trial data where you actually described there is user bias if it comes to ventilator. And then some users don't want to, do a trial, and in some instances also difficult to do a trial. You came to a couple of cases, beautiful describing, first one was a case where actually pi versus BPD, what lung am I actually dealing with? Because that, just the understanding makes your choice of strategy and tool very important. In the RDS, which everybody has tried, you sort of went over it, but every strategy sort of works. Impressive outcomes in anecdotal reports was a really interesting sort of statement around there. And then, of course, the most important part for what is happening now to us, where we feel where we are a little bit with our back against the wall, is that evolving chronic lung disease and the principles behind it. The case was very nice to explain the physiology, and that you have to target the treatment to the patient's lung, which you then went into the severe BPD, that it changes over time, and every baby does that differently. And I really like that summary in your setting. There's a lot of questions. The first one is from Ashok, which is about, when do they change? But I think you have answered that, but maybe the more important is the second question. Should we exclude all the other things or work on the other things like a PDA or infection? You mentioned ureaplasma.
Yeah, of course, there are other factors, and these hemodynamics contribute. Obviously, not enough time to get into all of the considerations, but yes, although, as you well know, the evidence that closing the duct is beneficial is scant to none. Maybe in some specific circumstances, it might be important to deal with it, but certainly a patent duct can make things worse. Closing it doesn't seem to make things a whole lot better, but it's something to certainly take into consideration. And of course, we know that if you have significant overcirculation, that compromises lung compliance. Gives you maybe a little bit of interstitial edema, makes him more prone to other complications. So, but yes, of course, you have to look at all the possibilities. When the baby's backsliding, it could be infection, new infection, acquired infection. It could be it could certainly be a PDA. So, obviously, the focus here was on the lung and the ventilation, but the questioner is correct in pointing out that there are other aspects that should be kept in mind.
So the second question from Kayatri, I had the same question in mind. Is jet ventilator a good tool in an acute situation, like an hypoxic deterioration?
Well, it depends on what the cause of it is, surely. And so, yeah, it's a choice of tools. So if the baby crumbs for some reason, so depends on the etiology. So if the baby has an acute abdominal event, jet's great because it can ventilate with small tidal volumes and less hemodynamic impairment. I didn't get into that, but that's one of the benefits of jet ventilation. If the deterioration is due to sepsis, the ventilator is probably the less critical component, and dealing with the infection and potential pulmonary hypertension is the more important. So again, it depends on what the primary problem is behind the acute deterioration. If there is pulmonary hypertension, you have to address that, and you want to avoid overexpansion and air trapping, because that'll, of course, worsen pulmonary hypertension by squishing the pulmonary capillaries. So you have to really think about what is the cause, and then pick the tool that will address it most optimally. As far as ventilation goes, sometimes that's not the most critical decision, and the other aspects are the more critical. But again, it shouldn't be a knee-jerk response. Baby's not oxygenating, oscillator is the better machine. That's actually not true. The jet has acquired a reputation from not being very good for oxygenation, but that's simply a function of the fact that it's often been used with a lower mean airway pressure. If you match the mean airway pressure between the jet and the oscillator, the oxygenation will be equally good. Gabby Musk did some nice work in your country with jet ventilation, and she did her PhD on that, and demonstrated that if you use enough PEEP, the jet's just as good as the oscillator in terms of oxygenation. So you don't need to switch ventilators. Often it's not changing the tool, but changing the strategy. That is the answer. People tend to mess with different ventilators, and they happen to pick better settings with the new ventilator than with the old ventilator, but could have achieved the same thing by just adjusting the strategy and sticking with what you have. But sometimes the tool needs to be changed as well, because the jet's better tool for certain things and not as good for other things.
That's probably where Mark Tracy's the next question is sort of related to, if you have a certain scenario, so you're using the jet a lot in your center, we would assume. So how often do you use high frequency? Is it even available in your unit?
You mean when you say high frequency, you mean the oscillator?
Yeah, oscillator.
Yeah. Yeah, it's available, and look, for a lot of things like RDS, it's where people trained and what they feel comfortable with. Both do just fine if you know how to use them. We have the oscillator, but like I said in the last slide, the jet can do pretty much anything the oscillator can do. So I don't feel like, for a long time, the jet was all I ever used. But then other people joined at Georgetown and wanted to bring an oscillator. Okay, we'll bring in the oscillator. The oscillator works. I'm comfortable with the oscillator. I did some work more recently with volume targeted oscillatory ventilation. It's great. You all have it. We don't in the US because FDA hasn't approved it yet, but it's another story. But yeah, so we use both. And there is no particular scenario where I would switch from the jet to the oscillator. People do switch from the jet to the oscillator. Mean airway pressure goes up by 5 centimeters and oxygenation improves. I say, okay, I can just increase my PEEP and I get the same result. So
yeah, the tool versus the use of the tool, and particularly the details and how to use it, remains important. There's a couple of questions about imaging, the added value of lung ultrasound. You mentioned it. Maybe EIT, is that something your center uses?
Yeah, so we don't have it clinically. I love EIT. I think it's a great tool. Again, it's not yet routinely available, and its clinical utility has not been definitively demonstrated, but it's great to have imaging help you visualize lung aeration and try to optimize dependent, non-dependent areas of the lung and such things. So I think it's a really nice tool. I know you have it more readily available in Australia and probably using it quite a bit more. I like the concept. We haven't had the neonatal size belts till recently, but they're now available. So yeah, it's a very nice tool. Lung ultrasound is also helpful. I'm kind of old-fashioned, and I still, think I can do a lot with just my old-fashioned clinical skills, but certainly the visualization is helpful, and we should be using it more. But we need a little bit more data, a little bit more, more studies to help. Like anything, those are great tools, can be used well or just not so well. And but yeah, I like them. I think they're helpful.
They're certainly increasing, I think, in our region, but not uniform there. But it's certainly happening. You explained about evolving BPD, the different types, and particularly pulmonary hypertension. Does your center screen for that on a regular occasion?
Yeah, we do. We routinely screen babies. So we have a BPD team that rounds on all babies once they reach the magic 36 weeks. But we will also get involved earlier if a baby is showing the pathophysiology. And so once the baby is demonstrating the phenotype of BPD, we do routinely screen with ultrasound for pulmonary hypertension. And anytime, and so if there's no pulmonary hypertension on the initial screen, if the baby continues to do very well clinically and follows the appropriate pattern, we don't necessarily rescreen. But if there's lack of progress or any deterioration, we'll certainly repeat the screen as needed. If there is significant CO2 retention, we worry about that worsening pulmonary hypertension, so we look a little bit more closely. So yeah, it's an important thing to do that carefully and catch it early. And these babies do respond to therapy, but it is a worrisome complication, and we pay a lot of attention to it. Early in my career, we had no idea this was going on. These BPD babies, they're always a little blue around the. We didn't worry about it too much, and then they were doing fine, and then crash and burn, and we didn't understand what was going on in the 1980s. Obviously, we do now.
Now, there's a beautiful, indeed. That's what the international people would tell about the recommendations. I love the approach. The clinical stable baby just once, but the other ones, you might want to recheck how often is still being debated, I guess. There's a couple of questions about settings, but I think we just have maybe time for one more. It's about brands. Does it matter? Does brands matter? Brands of ventilator?
Well. Features matter. So I don't know. So there are in the US, the people tend to use these universal ventilators that are adult ventilators that have been modified enough to be able to ventilate small babies, but not very well. Those I'm not a fan of. Ventilators specifically designed for babies are what I like. There are, of course, more of those available outside of the U.S. than in the U.S. So I've always used the Draeger ventilators, and they certainly do a very good job. There are, different ways of doing volume targeting. The algorithms vary somewhat. The leak compensation and trigger and termination different in some ventilators than others. There are obviously different ways of generating oscillatory waveforms. There's been much made about the power limitation of the Draeger at high frequencies, but then it's not a very important issue because you don't need a 5 ml tidal volume at 15 hertz. If your baby is needing 5 ml tidal volume, you don't want to be using a frequency of 15 hertz, so it's not a real issue. But yeah, you need to know your ventilator. You need to know its limitations. I love the leak compensation in the Draeger in that you can still get very accurate volume targeted ventilation with even a pretty moderately large leak of 60 or 70%. That's big. But you know, there's certainly different ventilators that do a good job. You need to know the limitations and the benefits of your ventilator, and then you're fine.
All right. Look, Martin, thank you so much for staying up late and this great presentation. Thank you, everybody, for attending. The recording is here. I hope to see you all, I think, next week or week thereafter when we have another webinar. But Martin, again, thank you so much. And I'm going to end this session.
It's been a pleasure. Thank you for having me.
Thank you.